What's up, guys? So today we'll go through myelodysplastic syndromes. So these are the important points. You should define it. You should go through the basic classifications. In our case, I'll go through the classification based on etiology and the classification based on how WHO have done it, and microscopic findings, clinical symptoms and complications, of course, treatment and prognosis. So here's the basic definition. It's just an overgrowth of an abnormal stem cell with maturation defects, right? So what happens is these these dysplastic stem cells accumulate in the bone marrow. They interfere with the maturation of the other cell lineages, so which is why ineffective hematopoiesis. And you might get a lot of cytopenias. Could be a single lineage cytopenia, multi-lineage cytopenia. But the key word here is dysplastic. So we know in pathology dysplasia is precancerous. So in this case, myelodysplasia is pre-leukemic, right? So these cells basically they retain the capacity to differentiate into specific cells, but then the way they differentiate is both ineffective and disordered. Peripheral blood might show one or more cytopenias, like I just mentioned, right? And the main problem with this is that these stem cell clones are very genetically unstable. They can very quickly gain more defects and will easily transform into AML, right? So this is the basic classification. Okay, before that, I'll just go through the epidemiology. Usually affects older people, men more often than women. And so firstly, classification based on etiology could be primary or secondary. Primary idiopathic is usually the one that affects super old adults, maybe over 60 years of age. Secondary, or I would also call it TMDS, therapeutic MDS, right? This may be due to the exposure to alkylating agents like chemotherapy or benzene or radiotherapy, right? Now, in terms of classification based on WHO, there is MDS with single lineage dysplasia, there's MDS with multilineage dysplasia, there's MDS with ringed sideroblasts. This one's important if you remember from learning sideroblastic anemia, that myelodysplastic syndrome is an acquired cause of sideroblastic anemia. There's also MDS with access blasts. This one is known to be the fastest subtype to transform into AML, right? And there's also chronic myelomonocytic leukemia. You can go through it here. This side is not as important. This is the old one. Robbins has this classification, but I think you guys should go through this one and for sure remember this. So the microscopy is very important because in terms of clinical symptoms and basically MDS is very similar to a lot of other disorders. So for example, it might show similarities to myeloproliferative disorders, right? As they're both myeloid in nature. There's massive differences in myeloproliferative disorders. You don't see as extreme of cytopenias, while in MDS, the cytopenias are one of the main distinguishing factors. In myeloproliferative disorders, you see decently adequate maturation of the cells, while in myelodysplastic syndromes, there's no maturation. Now, this is very important. The bone marrow is normal, but more likely hypercellular with dysplastic elements, right? You can use it to differentiate it from other causes of cytopenias like aplastic anemia. In aplastic anemia, you'll have hypocellular marrow. Um, of course, there's more blasts than normal, but it's less than 20%. As soon as they're over 20%, it's classified into AML, right? Now, the cells themselves are bigger in nature. If you see this cell right here, that's a dysplastic cell. They have a higher mean corpuscular volume because, as you know, that as these cells mature, they become smaller in size. In terms of microscopy, you might also see defective intermediates with structures such as karyophytes, which is just nucleus fragmentations, defective granules. You might see asynchronous development between the cytoplasm and the nucleus. Of course, you'll see you'll see macrocytic RBCs, right? Ringed sideroblasts specifically with iron deposits on the mitochondria. You might see weird looking neutrophils, right? They're called pseudo-Pelger-Huet anomalies. So instead of the normal 3-4 nuclear lobes, you kind of just have the neutrophils kind of just have two nuclear lobes. You might also see spawn ball megakaryocytes. Right, so the main thing is dyserythropoiesis, dysgranulopoiesis, and dysmegakaryopoiesis. Right, this is important clinically as the most common symptom is anemia because of dyserythropoiesis. Clinically, this will present as paleness, fatigue, malaise, dyspnea. You'll have higher chances of recurrent infections because of the cytopenias, like the leukopenias. Might also have bleeding disorders and easy bruising because of the thrombocytopenias. This is now the main complication why myelodysplastic syndromes should be caught early. It's because it's pre-leukemic. Eventually, it will progress to AML. About 50% of patients progress to AML, which is a tough disease to get. And of course, it has a higher risk in therapeutic related myelodysplastic syndromes. I'll just go through treatment and prognosis real quick. So in younger patients, stem cell transplantations are more effective as they have a higher chance of increasing their lifespan and their quality of life. But in older patients, just supportive treatment with antibiotics and transfusions should be preferred because these older patients usually have a worse prognosis and a higher risk of progression to AML. So in terms of prognosis, primary primary causes of myelodysplastic syndrome, these would these patients have a mean survival rate of 9 to 29 months, but this depends on a lot of factors, right? I mean, there's a prognostic scoring system. They've divided it. But in general, the more blasts and the more defects you have, the worse the prognosis. There's also some good prognostic groups. I don't really think you need to know specifically, but there's patients with the 5q and 20q deletion that have a very good prognosis. They could live up to 5 years. Therapy-related MDS, the cytopenias tend to be more severe, symptoms tend to be more severe, and the progression is much more rapid. So these have prognosis of 4 to 8 months, maybe. Well, that's it. It's a small question. That's honestly all you need to know for it. Thank you for listening.